Hi, Dr. Golewale. How are you?
I'm good. How are you?
Good, good. It's been a while. It's been a few months. I think we met at OEIS last. I hope everything's well. Thank you so much, Dr. G or Dr. Golewale. It's a pleasure to have you as our next guest on the Doctor Marketing Agency podcast. I would like to just talk to you about, I think, what's important is May is regarded, across the board as Women's Health Awareness Month. And it's kind of, underplayed because there are so many conditions that affect women as a whole. And I wanted to kind of shed some light on being able to, speak to you as a subject matter expert that deals with the embolization, treatments when it comes to women's health. But before I get into that, I first just wanted to kind of put it out there and kind of get a bit of an introduction from you as, what made you go the route of becoming an interventional radiologist? And what is, for our listeners and our viewers, interventional radiology all about, if you may?
Sure. Yeah. So I'm a MD doctor for about 15 years now, almost 15 years. Um, I wanted to be a surgeon. I wanted to work with my hands and do surgery and see the outcome. So I started my training with surgery. I was training in general surgery for a couple of years. And then I saw that most of um, some of the acute illnesses are now getting treated in interventional radiology. So I was in a level 1 trauma center in upstate New York, and anyone would come with any traumatic organ injury like spleen rupture or pelvic fractures, and if they are bleeding internally, I would think, before joining surgery, I thought that, we would be rushing them to the operating room and doing some cool surgery and saving their lives. But contrary to what I was thinking, we would take those patients to now interventional radiology in the middle of the night, and a IR doctor, a vascular interventional radiologist would come in and do an embolization procedure, with a very small pinhole size puncture on their upper thigh or through the wrist, and block or stop the bleeding. So that was very, excitement. I got very excited, seeing that, to see, if the patient was saved, but also there was no major, complications or side effects or anesthesia needed. Because
Right.
most of those patients that were coming in with those kind of trauma, they were hypotensive, they needed
Right.
IV fluids and, life support. Uh, Going through general anesthesia by itself would have put them at higher risk, of other morbidity and, or losing life or losing more blood. So that made me think like, hey, maybe, I'm I'm not in the right field, and I should be looking into the future, which is, vascular interventional radiology. And I loved, dealing with blood vessels and vascular anatomy. It just excited me from beginning, from my medical school years. And I also saw that, vascular interventional radiology was also doing all the revascularization procedures with peripheral arterial disease. And I did a lot of the wound care as a general surgery resident, burn units, and, the ICU setting and all that. And most of those patients with lower extremity wounds then were referred to or were treated by vascular interventional radiology. So that's what motivated me to switch my field, and I wanted to get trained into the more advanced techniques with minimal invasive procedures. So I switched from general surgery to interventional radiology. So interventional radiology, are board certified physicians who go through medical school. Like, most of general public may not be aware of, they have not heard of interventional radiology. They just hear of surgeon and medical doctors and
Right.
maybe cardiologist. The terminology is new to them for most general public. Now I think people are getting aware of what's IR or interventional radiology is, given the boom in OBL market, and people are now seeing IR doctors in the offices now in the outpatient setting.
Right.
But just for viewers who do not know what the IR, doctors are. So IR physician is a board certified medical doctor who goes through medical school and um, 5 to 7 years of after medical school training in minimal invasive procedures under image guidance. So we use X-ray, ultrasound, CAT scan, or sometimes MRI to guide our needles and catheters into the human body through a very small puncture in the on the skin, depending on what procedure we are doing, under mild sedation for the most part. Rarely any deep anesthesia or sedation is needed. There is, most procedures do not require incisions or cuts or suturing. That brings in very low risk, and I think that's what patients are looking for now is minimal risk, quick recovery. With the fast-paced world now, things they don't want to go to hospital and they want to get things done at the outpatient. So that's what our doctor does.
Okay. Well, thank you for that explanation, Dr. Golewale. I think that it's interesting to see how you transition from surgery and wanting to be a surgeon, and now you kind of summarize it quite well. That more and more patients out there are wanting minimally invasive care. They want to feel safe. They want to be able to come in and come out as quickly as possible versus a hospital stay, and be able to see subject matter experts, clinicians, physicians, doctors, providers such as yourself that are being able to treat them for this chronic inflammation or any of these issues that they might be experiencing. I think that, when people talk about radiology, if there was anything in the past that they might have come across was more on the diagnostic side, when they talk about imaging or ultrasounds or scans, as you had mentioned earlier, like, PET scans, CAT scans, MRIs. But I think with interventional radiology, it's, so reassuring for them to know that here's, a provider such as yourself that can be seen at any of your locations, either throughout Chicagoland or Indiana, or one of your team members that can basically be diagnosed and, determined if they need any particular treatment and, be able to realize that they can get back on their feet and enjoying the things that they love, which is so important. And I think that's what it's about. We speak about women's health, and I think this gives me the perfect opportunity to talk about overall women's health, Dr. Golewale. And one of the first things that comes to mind is that there's treatment out there that affects women when it comes to their pelvic pain. May also happens to be Pelvic Pain Awareness Month, and we think about pelvic pain and the fact that we talk about a woman's menstrual cycle or any of the difficulties they might have when it comes to the pelvic region, but ultimately a lot of them are not familiar with some of these treatment options that are out there for any diagnosis they might have. And one of the things that, is getting more attention and interest around it is pelvic congestion syndrome, or we talk about pelvic venous congestion. And, I think if you may, Dr. Golewale, kind of just give, our listeners and viewers an explanation as to what is pelvic congestion syndrome.
Yeah. So, I mean, it's a very broad topic. What you brought up is women's health and what, vascular issues that can happen in the, especially in the pelvic area that would, maybe causing the unexplained pelvic pain or pelvic pain that was not diagnosed or underdiagnosed. So pelvic pain in women, it's very common. It's often not talked about. It's underdiagnosed,
Right.
and then underserved. I think that a lot of women who silently suffering from this chronic pain in their pelvic area, with also associated with other symptoms like back pain, urinary symptoms, or constipation
Right.
with that, or pain with the intercourse and things like that. And the pain also, during menses or in between cycle, also associated with sometimes, visible varicose veins in their perineal or in the groin area or in the leg area, in the vulvar area and things like that. So
Right.
often, those patients, I think, usually seek help with their primary care doctors, and then often are referred to a OB or GYN physicians, who often, I think, are looking for some of the other, things such as fibroids or endometriosis, ovarian pathology like cysts and things like that.
Right.
Um, but they may or may not find they may or may not come to the right diagnosis, or sometimes requires more invasive procedures like laparoscopy or invasive surgery and hysterectomy and things like that. Often the vascular issues had been ignored in the past, but now we know there is something called pelvic congestion syndrome. So basically, to answer your question, I think in a simplest term for viewers to know is basically it's a venous reflux of the pelvic veins.
Right.
So I think everyone is aware of the venous reflux of lower extremity, which can cause varicose veins. And often people come and say that, hey, I have varicose veins. Varicose veins is just a symptom or a sign of venous insufficiency or venous reflux. So we need to see what the underlying pathology is. If we know the root cause, then we can treat the root cause. Often people just go for, like symptom treatment or a sign treatment rather than the root cause treatment. So in pelvic congestion syndrome, it could be either reflux in the pelvic veins because of either obstruction, such as, we call May Turner or old, maybe it's a undiagnosed or a known DVT or a blood clot in the pelvic veins, like iliac veins. Or it could be reflux or venous insufficiency in their ovarian veins. So whether either it's a blockage issue or a reflux issue, it's one of the most common reasons to have pelvic pain. So usually the women who are affected are younger women or middle age, I would say 20 to 50 years of age. Most of them have pregnancies in the past. And have been silently suffering for a number of years. So now, there is a vascular reason for this pain. So now we do get referrals from GYN or primary care doctors, or most of the time now patients are looking up on their own, and then they are not finding any solutions with other physicians, regular physicians that they usually go to, like GYN doctors and things like that. On their own research, now they think that, why don't we just look into the vascular reasons why, that might be a reason for my pain, because it's not getting better with all the other treatment they had. So to answer your question, pelvic congestion syndrome is a very common disease. A lot of women suffer from it. Coming to the right diagnosis is the key to get to the treatment for it.
Now that's very, well thought of and elaborate answer there, Dr. Golewale. You kind of explained is, what it is, and you've also touched on, who is at risk of it. You mentioned in terms of a vascular perspective, because, the referrals come in from an OBGYN or, a PCP. But I think what you kind of touched on is important, because we talked about this earlier. We talked about minimally invasive procedures. When we speak about pelvic venous congestion or pelvic congestion syndrome, one of the, as an IR, minimally invasive procedures that it's treated with is through ovarian vein embolization, right? Is that something that you can just explain and, touch on and elaborate a bit more about specifically?
Of course, yeah. So ovarian veins are, or gonadal veins. Like we have testicular vein in men, we have ovarian veins in women. These are the veins which surround and drain ovaries. Since there are two ovaries, right and left, so we have right and left ovarian veins. And then the veins in general are, I give example to my patient as septic system of the house. It's supposed to drain away from the organ or from the structure that they are draining.
Right.
So it should move away. So the blood in the veins should be moving away from that primary structure. So ovarian vein should be taking the blood away from the ovaries and should go back to the heart. So it can get, the clean blood can then come down. So ovarian vein reflux is basically the backward flow in the ovarian vein that is coming down instead of going up the leg. Sorry, up the veins, up the ovarian vein. So on the left side, for example, the ovarian vein should be dumping the blood into the left renal vein or left kidney vein.
Right.
So if the blood is flowing backward, that means the blood is now pooling around the ovaries, and that's what we may call as a congestion or overflow or two distended veins. So that's what we call that venous reflux. Reflux is backward flow. In the embolization procedure, we go in through those, so we need to get to the ovarian vein. So we find a pathway to get there, either through a catheter through the upper thigh or through some doctors do through the neck. jugular vein. So eventually we reach the ovarian vein, demonstrate the reflux or the backward flow, and do this procedure called embolization. So embolization means blocking a blood vessel or slowing down the blood vessel. Or when in layman's term, we are basically gluing that vein or that blood vessel. So we are blocking it or gluing it, so there is no longer blood pooling in that vein. So then hence there is no more congestion and there is no more distension of that vein. Hence there is no pain. So the goal is eventually to help with that pelvic pain or chronic, pelvic congestion syndrome by embolizing or going for the root cause why there is pain to begin with.
That's very insightful, Dr. Golewale. I think that at the end of the day, there's so much of information out there, and we've realized that a lot of people are going online. They're trying to get more information where they want to obviously reach out. You mentioned something earlier about pelvic pain, and getting to either see an OBGYN or doing some research to then to discover that it's actually vascular related. But I believe that in terms of the difference, there is a difference between pelvic congestion syndrome and endometriosis, although they both seem very similar. Can you just kind of highlight that, what is actually the difference between those two, and what should someone be looking out for in terms of, potentially reaching out to speak to either, yourself, or reaching out to an OBGYN or a PCP if they feel they might have pelvic congestion syndrome versus endometriosis?
Yeah. Well, in the endometriosis, basically it's the lining of the endometrium, which is the inner lining of the uterus. It can have deposits outside the uterus,
Right.
or there is a lining could get thickened inside the uterus. So most of that pain is usually around menstrual cycle. With the monthly cycle, sometimes really it can be intracycle pain or bleeding, but most of the time it's it's very correlated with the woman's menstrual cycle. But in the pelvic congestion, it's obviously there are very two different diagnoses. By the way, interventional radiology can treat both of those treatments, especially if the endometriosis is restricted to the lining of the uterus, not outside. So we also can perform uterine artery embolization for those procedures.
Sure. Yes.
But for pelvic congestion, obviously, we're looking at it's a very different diagnosis, very different method of looking at what's going on there. So these patients may need some other imaging testing like MRI. Sometimes if the diagnosis is not clear, MRI would show us if there are thickening of the lining of the endometrium or lining of the uterus, if there's a thickening there, or there are deposits of this, or we call islands of the endometrium outside. They can be in the pelvic region, or it can be on the ovaries and other areas. And also MRI can also show if there are distended veins in the pelvic area. It can also show dilated ovarian vein in the pelvis. It can also show if there is May-Thurner or compression of the iliac vein, which can be associated with ovarian vein reflux. So we didn't talk about that earlier. Often people aware of, some people now are getting aware of the May-Thurner or iliac vein compression.
Right. Yes, I've seen that.
So which often is associated with venous reflux, or can be a part of the whole spectrum of pelvic congestion syndrome, or vascular reasons for pelvic pain. So in my practice, I always look for iliac vein compression in women who come with this pelvic pain or pelvic congestion syndrome. Often, sometimes just treating the iliac vein itself can relieve most of the pain because there is no more back pressure into the internal iliac veins. So often you see the reflux into the internal iliac vein from the common iliac vein compression. So once you relieve that compression, then there is no longer obstruction to the flow, and that helps relieve some of the backward flow. So the deep veins of the pelvis and the ovarian veins are all connected together. And of course, we also look at the renal vein to see if there's any compression of the renal vein and things like that.
It's very interesting if you look at that entire anatomy and region, because You're mentioning on things that, more and more people are getting familiar with. You mentioned May-Turner syndrome. You mentioned the iliac vein, and how we kind of, refer to ovarian vein embolization or gonadal vein embolization. So I think that that's important that, there's that reassurance and, option that, these women have if they have to reach out to a practice such as yours to determine if they are, experiencing this issue and they could be a candidate for this type of embolization. But on that topic, I think it's a perfect opportunity for me to kind of go into a different segue. But again, talking about women's health, Dr. Golewale, something that I think is more common that women feel that they are doing a lot of research on, they are going online and searching, they're seeing a lot of content on social media, and they are experiencing and talking with one another in terms of colleagues that have actually gone through this. And that's what we talk about varicose veins. It's such a broad topic, but I think that so many women are impacted or affected by this. It's not just to say that only women are affected, but I think that issues that women have, especially after pregnancy and, kind of, experiencing this, it's definitely something that there are, hundreds of thousands of women that go through this, in the US as well as internationally. And in your take with this, Dr. Golewale, why are so many women prone to varicose veins?
Yeah, good question. So again, varicose vein, like I was saying earlier, it's a symptom or a sign of an underlying condition called venous insufficiency or venous reflux. So then we are looking at like, hey, what is venous reflux? So just to spend 30 seconds on that, basically there are valves in the veins, in our leg veins. Think of like a check valve. And if the check valve is leaking, then the blood is flowing backward. So the blood in the veins in the leg should be going up the leg towards the heart. And if the valves are not completely closing or this check valve is leaking, then the blood is leaking or seeping through backward through the valve. And now there is more tension. One of the other term is peripheral venous hypertension. So there is extra, more pressure in these veins, and eventually that flows back and backs up into the surface veins. And now we are seeing as varicose veins. So varicose vein is not a diagnosis; it's one of the symptom of venous insufficiency. The other symptom could be leg swelling, which is again very common in women, and along with varicose veins, there can be skin changes or skin discoloration and things like that. So why it is more common in women? So what are the risk factors? One of the main reasons is women goes through pregnancies.
Right.
So one of the as there is more increase in the pelvic pressure, and going back to the pelvic veins, and we discussed earlier, the growing baby and as the uterus enlarges, as the pregnancy progresses, can put pressure on those deep pelvic veins, which are the iliac veins. Some people call iliac veins. So as there is more pressure in the pelvis, and the pressure needs to be transferred somewhere, so that gets transferred back into the legs, because those leg veins are connected to those pelvic veins. The blood flows, upward in that direction. So if there is a blocking or blockage or narrowing of those pelvic veins, then the blood has no passage going back through its normal route, so it stays longer in the leg. And anytime it stays longer in the leg, that's when we start seeing those varicose veins or skin surface veins pop up. Again, we see more on the left side. I always tell my patients, if I see 10 patients today with varicose veins, 8 or 9 out of 10 will have most of these varicose veins on their left leg than the right leg, again, because of some anatomic reasons. There is a genetic factor or familial involvement. So if your parents had varicose vein problem or venous insufficiency problem, then it's most likely that you're also going to have, and also the workforce, women mainly are working in standing position, whether it's a household work or if it's a desk work on a computer work, whether they are teachers or cashiers and or they are nurses, or they could be physician, or could be, women are in every workforce nowadays, but most of the work that involves standing, sitting long hours also predispose one to get venous insufficiency, which then leads to varicose veins.
Yeah, I think that's well explained. If you look at the workforce and you mentioned, cashiers, you mentioned nurses, you mentioned, even fields like being security guards, more and more women are getting impacted by this. But to your point, I think that pregnancy, over and above the body changes and, the pressure that you kind of get to that, they become more susceptible or more prone, to, definitely, being affected by or impacted by varicose veins. So what symptoms beyond appearance should people watch out for, Dr. Golewale, if they feel they might have varicose veins?
Yeah, I mean, most commonly, or initial symptoms usually is ankle swelling or swelling around their feet or ankles. Again, it's very common. A lot of people think that, hey, it's just part of aging or it's normal. I've seen other people's ankles being fat. They think that it's just normal, but swelling in the ankles is never normal. There is always a reason why. Normally the ankle shouldn't be swelling. And most of the time, the swelling is, we see is towards the later part of the day. When they wake up in the morning, they may not see much swelling in their legs or feet or ankles. But if you start seeing swelling at the, in the later part of the day, because we were standing or sitting throughout the day, then we start seeing it. And then, of course, pain or, I never want to just say pain because some patients do not experience pain, but they describe it a different way. Some say heaviness, some say cramping, some say tiredness, some say cramp, like a Charlie horse. And people describe different ways, or something like achingness. Because oftentimes when I ask, I used to ask patients in the beginning of my career, like, hey, do you have pain? They would say, no, I don't have pain. I have achiness. And said, okay, so that's what I meant, so if you have pain or achiness, for me, it's, for the doctor, it may mean the same, but for a patient who's describing it, for them, it may have a different feel to how they feel, what they're experiencing. So the symptoms are, again, going back, swelling, pain or achiness, tiredness, heaviness, cramping, restless leg, itchiness in the leg, skin discoloration. Oftentimes we start seeing pigmentation in the lower legs, dryness in the skin or scaliness. And if it's untreated, it can cause more skin thickening or scarring. And then later stages, it can in fact cause some blistering or ulceration and wounds and things like that.
For sure. I think that, there's so many, symptoms that they could look out for, because it's not just being cosmetic. But I think you hit the nail on the head, Dr. Golewale, when you mentioned that, how the patients classify it, as heaviness. Some of them, see the discoloration, the restlessness, and so on. But ultimately, at the end of the day, the common factors are that they've got to be careful, look out for this, swelling, kind of, if they feel that they could be, potentially diagnosed with something like this, do their research and be able to realize that, there's a practice such as yours at, NG Vascular and Vein Center that they could reach out to when it comes to, getting treatment for this. But on the topic of treatment, and also once more, we talk about minimally invasive treatment options there. Dr. Golewale, I know there's quite a few out there that, people can obviously research about. We talk on the one hand about things like sclerotherapy, endovenous laser therapy. We talk about, ambulatory plectobectomy. We talk about, compression stockings, etc. Can you just explain to our listeners and our viewers that some of the treatment options there are there that your practice can obviously offer when it comes to varicose veins and the issues that they are maybe experiencing?
Sure. Yeah, just to keep it, discussion short, because, we can go a lot into details of it.
Sure.
I always ask patients if they're wearing compression socks. The graded compression socks, prescription strength is important. If they were not wearing it, we always prescribe them and tell them to start wearing compression socks. Most patients, by the time they come to us, they have been wearing socks or compression wraps for a while. And then from that point on, from the medical treatment, yeah, like you said, again, we got to treat the source. I always, some patients come to us and they say that, oh, I had the treatment elsewhere. They injected my varicose veins or my spatter veins, but I'm still having the same problem after a year, 2 years. The reason being that they did not treat the root cause why you have varicose veins. So I always want to treat the cause, the root cause. So going back to our initial discussion of those leaky valves or leaky veins or reflux in the veins, you treat those saphenous veins or great saphenous veins, small saphenous veins. So the treatment, for those could be of various kinds, depending on, again, we decide based on the patient age, what size of the vein we are treating, the location, There's a lot of factors go into it.
Right.
How much
Sure.
reflux do we have in the anatomy of the vein? So typically, it could be a glue procedure called vena seal. That's quite popular nowadays because less invasive or less painful. Or it could be EVLT or laser treatment or thermal ablation. That could be laser or it could be radio frequency, or sclerotherapy for most of those either branching varicose veins or spider veins. That can be done with like a foam sclerotherapy. Phlebectomy also, can be done, and that's somewhat more invasive, where small, cuts or incisions are made on some of the bigger varicose veins, and essentially they are removed. Um, so that can have some bruising and things like that. For in my practice, for the most part, we rely mainly on sclerotherapy for most of the superficial veins, and then the source veins, we treat with either thermal ablation or with non-thermal, which will be like glue technique.
Right. I like that explanation a lot there, Dr. Golewale. I think that, we talk about the root cause, and that's so important because the one thing you don't want to see, as a provider, when you're seeing patients that are coming back, having been treated at other, facilities or outpatient centers, whatever the case might be, and, you're not realizing that is actually the root cause that needed to be addressed, because otherwise, they are like, why is this happening to me again? Why do I have to go through this treatment again? And I think that's so important that that gets kind of focused on. Lastly, on the topic of, varicose veins with regards to women's health, Dr. Golewale, what does that recovery look like, for a woman that's undergone this minimally invasive treatment? What should they expect to be able to then, look forward to being able to do once more? And, is there a certain period of time once this treatment is over that they can get back to their daily lives?
Sure. Yeah. So most of the treatments I described, they are minimal invasive, they're outpatient, it
Right.
doesn't take too much time in the office setting. Some of the older ways of treating these varicose veins and venous reflux was hospital procedures and required longer recovery. For most of our patients, depending on, is a very detailed scan that is done initially when they come in for a consultation. It's called a ultrasound or a Doppler of their veins or vein mapping or venous insufficiency scan. So that's what gives us a roadmap of their veins in the leg. So how many these leaky veins or diseased veins that they have that we need to treat. So based on that, we make a plan, a treatment plan, very very specific for each patient. Again, with the pictures to see where those veins are and how we're gonna treat each vein, and how we complete the entire treatment by to go after those root cause. So typically, these are weekly appointments. Usually, some patients come every other week. Most patients try to come once a week. These are, with the lengthwise, it depends on how many veins we find. And the recovery wise, it's very quick recovery after each treatment. Patients can be up on their legs pretty much right away. They don't need to be off from work and things like that. Most of our patients, they come from work and during their lunch break or their break in
Right.
the, in the middle of their day, and then get these treatments, and then they go back to work. Or they go back if they're at the end of the day, they go back to shopping, they go back to their their homes and go back to their routine activities. So most of these venous or varicose vein treatments are minimal invasive. There is not much pain or discomfort afterwards, and they can go back to their activities pretty much right away.
Yeah, for sure. I think that's important and reassuring for patients out there. These women are obviously, experiencing this discomfort and pain. And I think the more and more options that are minimally invasive allows them to realize once they undergo these treatments that just get back to the quality of life that they had, spend time with their kids, spend time with their family, doing the stuff that they love, and just being able to move forward, and literally being able to, get back on their feet and feel their legs again. It's interesting you mentioned this and the issues that women are going through. One of the other things that I'd like to discuss and talk about, Dr. Golewale, is that May happens to also be very interestingly, World Inflammatory Bowel Disease Awareness Month. It also talks about digestive health when we have on May 27th, World Digestive Health Day. And, we give it a lot of thought, but how an interventional radiologist can definitely assist, potential patients out there that are experiencing problems. And one of the issues is that if inflammatory bowel disease causes hemorrhoids,
Yeah. Um, so I like the way you tied everything together with, uh, venous disease and pelvic congestion and then the hemorrhoids. I think they all, I would take it as a, again, as a spectrum, very common in women, very common in younger women, again, younger or middle-aged population. Um, Again, why it is, we see more in women because of, as they go through pregnancies, again, we see the pressure building in the pelvic veins and the labor that they go through, or childbirth, that can lead to uh, the congestion of those blood in the pelvic vascular structures, and thus leading to the hemorrhoids. So the hemorrhoids are one of the reasons for lower digestive pain or bleeding or discomfort. Again, that's one of the topics most patients don't want to talk about or don't even mention to their doctors. They are again silently suffering for years. Most of the patients that they come to us, when they see that the treatment that we have to offer is so minimal invasive, there is a stigma with hemorrhoids that it is painful condition, but also the treatment is even more painful. That's been a normal knowledge among general public, but that's not the case anymore. With some of the newer treatments now out there, we can fix or treat the hemorrhoids without much pain afterwards. Um, so with the outpatient-based treatments or with interventional radiology treatments for hemorrhoids, mainly they are internal hemorrhoids. So most of the patients that they come to us, they have pain, they have discomfort, they have bleeding. It's very common with these big hemorrhoids and large hemorrhoids, and just a discomfort, or itchiness and things like that. And most of them, they already have tried um, over-the-counter treatments like preparation H. They have done the sitz bath, improving their bowel habits and avoiding constipation, and all of those things. And if they are not getting better, then they come and seek help from us to treat hemorrhoids. And there is a treatment that we do called embolization or hemorrhoid artery embolization. Again, it's a minimal invasive outpatient. Um, I never say no pain to any patient, but knocking on the wood, not a single patient has complained that they had pain with this procedure, doing or afterwards. With by now doing hundreds of these procedure, and we have seen a significant success. Majority of the patient had relief from their hemorrhoids, and the best part was it was not painful recovery. The
Right.
traditional treatments that typically were offered in medical field with for hemorrhoids were either banding, um, band ligation, or hemorrhoidectomy, which is basically removing the hemorrhoids with a surgical technique. That's most painful. Most patients would have to pretty much sit on a donut for several weeks because the pain that they had to go through. With embolization procedure, we're not cutting on the mucosa or on the hemorrhoid itself. There is no incision, there is no knife involved, there's no scalpel involved. These are treated from inside through a blood vessel. So yeah, I mean, I think that's a hope that these patients have, that there's a good treatment with very minimal pain, if any.
Yeah, you bring up is such an important point, Dr. Golewale, because I think you mentioned the stigma. It's almost as if it's taboo when patients don't talk about this, and they end up suffering in silence. But at the end of the day, it might be in a very painful region, but it's so good that we mentioned about hemorrhoid embolization or hemorrhoid artery embolization or hemorrhoidal artery embolization, because it's different to the hemorrhoidectomies, which is painful as a surgery. It's different, if they've tried banding, and at the end of the day, it's become a procedure that's become very much more popular in recent times, that IRs are performing, because I think patients realize that they don't want to be in this discomfort anymore. And once again, both women and men might be affected by this, but those women that are experiencing this need to realize that if they look at the literature, do some research, and do a bit more of an understanding around this, that they've got this opportunity available to them. because, pain is something that becomes, significant throughout the board. But no one wants to go with, difficulty in terms of certain pain that impacts their daily life. And I think with hemorrhoids, once there's something such as bleeding, it becomes an issue. And it's so reassuring to know that if they come through for a procedure such as this, it's quick and easy, in and out, and it avoids them having to go for the surgery, as we spoke about.
Yes, no, definitely. So, like I said, it's a hope now that most these younger patients have, the constipation and irregular bowel habits have become quite common with our Western diet. And a lot of people, I think, have to spend longer hours on the toilet. Plus some of the other reasons we talked about. Hemorrhoids has, becoming more common in the, in the population, especially younger population now. And the treatment have not evolved. The treatments were all same up until now. Now with the newer treatments, called, like you said, HAE or hemorrhoid artery embolization, which can be done as an outpatient, again with no incision or no cutting on the hemorrhoid itself, but we go through a blood vessel in the upper thigh with a small pin-sized hole in the skin, just with the local numbing medicine and maybe some mild sedation, like mild twilight, and there is no there is no pain, or almost no pain during the procedure, and then during recovery also there is not much pain. So basically, we embolize these blood vessels that supply the hemorrhoids. The hemorrhoids are, the goal is for them to stop bleeding. That's usually the first thing I see is if they were bleeding, then they stop bleeding, and then the shrinkage does take some time. It may take few weeks because it's shrinking from inside out. So, but the alternatives that the patients had before this new treatment had not much evolved in the past several decades. So now I think that now it's a good hope now. It's a new hope.
Sure. Well, thank you so much, Dr. Golewale. I think this has been such an enlightening session. I think that the education that you've provided is so important because, we cannot take our health for granted. At the end of the day, patients, if they are experiencing any of these issues, whether it be the varicose veins, the pelvic congestion syndrome, the, hemorrhoid issues that are creating the bleeding, they need to be able to, reach out to a practice such as yours to realize that at the end of the day, there is this option that can provide this minimally invasive treatment and allow them to get back to doing the things that they love, spending time with their family, being pain-free. It's just, literally a phone call away, being able to go and, visit a practice such as yours. And I think it's important that if they have any questions or, need to do any research, that they're able to obviously reach out. We don't want people to kind of hold it in. And, health is overall so important. So now is the best time, is in the present for these prospective, patients or experiencing these issues to definitely reach out. It was a pleasure having you as a guest on board. I'm sure this is going to be a very, enjoyable session for a lot of people to be able to listen to and watch to. And all the best for you and your practice. And we will definitely speak down the road.
Awesome. Thank you. Thanks for having me.
Thank you so much. You're welcome. Have a good one. Take care, Dr. Golewale.
Thanks, you too. Bye-bye.
Thanks. Bye-bye.